Today's episode is brought to you by Microsoft, who is committed to helping physicians reclaim their work-life balance and restore the joy of practicing medicine. Discover DAX Copilot, your AI assistant for automated clinical documentation and workflows. To learn more about how DAX Copilot can help improve healthcare experiences for both you and your patients, visit aka.ms/knock-knock-hi. Again, that's aka.ms, like Microsoft, /knock-knock-hi.
Knock, knock. Hi.
Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glaucomflecken, your one-stop shop for eyeball stuff. Today was a good day. I was in clinic. I'm recording this on a Thursday. And the theme for clinic for today, a full day of clinic. I'm beat by the end of ophthalmology clinic. Typically, I see around 40 to 45 patients. And people always think that's a whole lot, but it's actually probably on the, I was not on like the low end, but just right smack dab in the middle on average for a private practice ophthalmologist. But keep in mind, like our exams, everything, it's very focused as opposed to like an internist or a family physician who've got like an entire human body to take care of. I have these little things and the skin and the tissue around it. So we can see a lot of patients, which is good because a lot of patients need to see us. But today, there's always a theme to a clinic day. And today, the theme, unfortunately, was dry eye. I have, whenever you're describing the common things that you see, like as a physician, you have the same spiel. This is the same thing that you've said thousands and thousands of times throughout your career. Like I've got the same thing I say for like introducing people to the idea of cataracts and posterior vitreous detachment, flashes and floaters, macular degeneration. What is glaucoma? All these things have like a script that I don't have written down. It's just in my head. I just end up saying the same things over and over again. Well, dry eye is no different. And it was a lot. There's a lot to talk about and explain about dry eye. And so I did that like probably 15 or 20 times today. And I don't even want to think about dry eye. But I will for you, briefly, and just going over the pathophysiology and there's 1,000 different treatment options. And a patient that I saw, and this happens every now and then. I try really hard not to like say anything negative about my fellow eye care professionals. And I don't to patients ever. Like it doesn't even matter if what somebody did to a patient or advice they gave was wrong. I will correct the information if I think it needs to be corrected. But I don't say anything like about that person. That's like the doctor code. You just don't do that. All right. It's not because you don't know in the end, you don't know really like what happened between the doctor and that patient. Is someone misinterpreting things? Was there actually incorrect information given? You just don't know. But this is something I've seen like a few times from other people out in the community in the dry eye space. And it bothers me. I had a patient come in for a second opinion about their dry eye. And this patient was told that they needed roughly $2,500 worth of expensive medications and in-office procedures to treat their dry eye. And was rightfully like, let me just like double check that with another doctor and see if they say the same thing. And so I saw this patient. They did have some dry eye, but did not need all of the things that were recommended by this eye care professional. And I told the patient that I was like, no, I don't think you need LipiFlow or IPL, or this is all this out of pocket stuff. And I've said the same thing for, I've seen patients like that who were recommended LASIK and probably shouldn't have gotten LASIK. So there's lots of different things. And usually, it's just like expensive cash pay things. And so what's the lesson here? I just gave the correct information, and the patient appreciated that, and the patient went on their way. And I'm not sure, maybe they're going to go back and get some of those treatments. I don't know. I told her what I thought and what I would do, how I would treat her dry eye. But what I want you to take away from this is that as a patient, like, never feel bad about getting a second opinion. Like, I will sometimes, if I can tell a patient is skeptical about the treatment that I'm recommending, sometimes I will tell patients, I'll be like, I'm happy. I can tell you're not quite on board with what I'm telling you. It's okay if you want to get a second opinion. I can recommend somebody to you. And that's, I promise you, any physician should be fine with that, because in the end, it's your health, it's your body, it's your money. And for me, as a physician, as a surgeon, I don't want to do a treatment on anybody who is not sure that they want that treatment. I want us to be lockstep. Yes, this is necessary. And so don't hesitate to ask for a referral to get another opinion because you're not sure. Nothing wrong with that. I encourage it. You need to be educated about your health, and you need to make absolutely sure that this is something you want to do. So I applaud that patient that came in to see me for a second opinion, because it's it's important. We need to encourage people to practice their own autonomy and be autonomous and exercise their power as patients. All right, so real quick here at the top, I had just looking through the comments on our YouTube channel at Glaucomfleckens, the last Knock Knock Eye that was published here. This is a good question. At Rachel Rack 4502 said, "Would you like to talk about the subspecialties in ophthalmology? I had an experience that required one of them as a teenager, neuro-op, and it would be cool to spread the word on what's out there related to your field." I love that. I think in the past I have briefly just run through as wow, isn't this ridiculous that the eye can be separated into 7 different parts and we have specialists for all of them? But I don't think I've ever actually talked to you about what they are. So here, I ordered these. These are going from easiest to find to rare gems in ophthalmology. The rarest, the hardest to get an appointment for. Okay, so easiest. And some of this is very subjective. Actually, all of it's subjective. Although a few of them I'm 100% sure on. Some of them I'm just kind of guessing. I didn't do enough research. I didn't I can't say this is fact. So it's mostly my opinion, but probably correct. So most the easiest to find. I'm not including cataract surgeon because that is the easiest to find. Cataract surgeons are everywhere. Because every physician who graduates residency can do cataract surgery. All right, so I'm going to start with refractive surgery. So those are your doctors that are doing LASIK and PRK. They're easy to find because they're cash pay and they make a lot of money, and so you're going to see a lot of advertisements for them. So if you're looking for a LASIK surgeon, it is not hard to find a LASIK surgeon. So that's one subspecialty you can do a fellowship in. So by subspecialty, I mean after residency, you finish that's what I did. I residency and I was done. I was a comprehensive, that put me into the category of comprehensive ophthalmologist. A subspecialty, you do an extra year or 2 in a subspecialty within ophthalmology. So refractive surgery, that's the first one. Second one, cornea. And a lot of times these go hand in hand. So some people are just refractive surgeons. Some of them are refractive and cornea. Some are just cornea. So the cornea, this 550 micron part of the eye on the front, you just specialize in that. You just do a bunch of that. Common things that you would see as a cornea specialist. You would obviously, like we talk about maybe refractive surgery, corneal ectasias like keratoconus, pellucid marginal degeneration. You would see inherited corneal dystrophies, epithelial basement membrane dystrophy. There's random ones like granular dystrophy and some of the less common ones. Then you see, bad corneal ulcers, infections, chemical burns, really any more advanced pathology related to the cornea that a typical ophthalmologist like me, maybe it doesn't feel quite comfortable treating. That's a cornea specialist. Very common. Next, I'm going to go with retina. Retina surgeons are everywhere too, all right? Because retina is big right now with all the intravitreal injections that are done. Our retina surgeons, as part of our practice, they probably do like 50 injections a day. It's a lot because this is macular degeneration that people are treating, diabetic macular edema, neovascular changes in the back of the eye, lots of things. And so retina is a very common subspecialty, very important. One of my favorites because I don't want to go back there to do anything. It's scary. It's a scary place, the back of the eye. Next, I'm going to go with plastics. I think that's the next easiest. But now we're getting to a little bit less common. And part of this is because oculoplastics, there's not a whole lot of fellowship programs out there for them. And often they're 2 years. So it dwindles the pool of people that choose to do that subspecialty. But oculoplastic surgeons they deal with diseases of the eyelids, entropion, ectropion, dermatochalasis, ptosis, raising up eyelids, sometimes lowering eyelids, tightening up eyelids. They do a lot of cosmetic procedures as well, brow lifts, and Botox. A lot of oculoplastic surgeons will do some Botox, and also orbital issues, orbital tumors, thyroid eye disease. That's your oculoplastics doctors. All right, then glaucoma. Actually, maybe I should have switched. Glaucoma might be easier to find than oculoplastics, but probably very similar. Glaucoma specialists, this is also a very hot specialty right now because there are a lot more surgical treatments for glaucoma that have exploded over the past year. Maybe I'll do an episode pretty soon about all the different things you can do surgically with glaucoma. But glaucoma is a disease where high pressure inside the eye causes a damage to the optic nerve, resulting in peripheral vision loss. And there's a whole specialty, a whole science, a whole wealth of literature and research going into this one disease because it's a very common disease. Big time cause of vision loss out there. All right, then we have... let's go with pediatrics. All right, now we're getting to, I'm doing a lot, maybe I skipped a couple like ophthalmic genetics, ophthalmic pathology. These are very, very common. So I'm not even going to really address them. Pediatrics is getting more and more scarce. It's almost a crisis in ophthalmology right now. The lack of people going into pediatrics. And just like most things in medicine, the biggest reason why is because people say that there's not as much money in pediatric ophthalmology. And that's true, I guess, compared to some other subspecialties in ophthalmology. But the pediatrics just in general is not a prioritized field. And there's not as much attention. People aren't focused as much on, they're underpaid. Pediatricians are underpaid, underappreciated. And that extends to pediatric ophthalmology. We need more pediatric ophthalmologists to do things like strabismus, congenital cataract, treating eye diseases of childhood. There's like rhabdomyolysis and there's not rhabdomyolysis, rhabdosarcoma. That's what I'm thinking of. I guess rhabdomyolysis, that's a possibility. I don't think that would really affect the eyes as much. Sickle cell disease is something that you'll see. Any kind of congenital disorder that affects children. There's a whole host of them, inherited retinal diseases. So it's a big field. There's a lot of directions you can go in pediatric ophthalmology. It's a very exciting field, but often very underappreciated. But we need more. We need more of them. In fact, I think some people are talking about maybe having a pathway to pediatric ophthalmology through pediatric residency, not ophthalmology residency, which sounds incredibly challenging to me. All right, and then the rarest form of ophthalmologist of all is the neuro-ophthalmologist. In fact, they're so rare, I think there's only 3 of them. And they move around the country, so you never know where they are at one time. I wish I could have a neuro-ophthalmologist working with me at all times, because if I'm ever not sure about something, it's usually because it's a neuro-ophthalmology problem. It's a very difficult subspecialty, very cerebral. I would not consider myself a cerebral person, but it is. And so we need more of them as well. If anybody's interested in being a pediatric ophthalmologist or neuro-ophthalmologist, please talk to me, because I'll try my best to convince you. I don't know if I'm doing a great job right now, but I can. Anyway, those are all like the major subspecialties. Again, genetics, pathology, uveitis is another one. These are very, very small. Very, 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 very small. Anyway, still kind of blows my mind that you can do so many different like careers. And the reason I chose none of them is because when I was going through residency, by the end of each one of these rotations, because you rotate through all these different subspecialties so you can see as much as possible in the short amount of time ophthalmology residency it lasts, I chose to do none of them because by the end of every rotation, I was bored to death. At the end of glaucoma, I was like, please, nobody ever say IOP or tonopin or trabeculoplasty ever again, or trabeculectomy. I don't want any of that. I don't want to do any of that. Same with retina. Same with cornea. I was done. So that told me right there, maybe I should just do it all. And I became a comprehensive ophthalmologist. Let's take a break. All right, I've got an interesting case for you all. Sometimes things come into your clinic that scare you. You know, I've had harrowing adventures in the operating room, difficult cases where things go wrong, your blood pressure rises, you're stressed out, you're sweating. That's one thing in the surgery, but it doesn't happen that often in clinic. But I had an experience like that. And I'll tell you about it. It was a while back, probably early in my career, where I have confidence, like I'm doing well. My clinic's busy. I'm able to keep up in clinic too, so I'm not just running around like a chicken with its head cut off. I'm actually like doing okay as a practicing ophthalmologist. And on this particular day, I was the emergency on-call doctor for the clinic that day. So the way it works in our clinic is we always have one doctor in clinic who is not on call at night, overnight. We're on call for the clinic that day. So if we get a phone call from an urgent care or emergency department or urgent calls from patients, their eye hurts, they've lost vision, bad car accident, trauma to the eye, then, I'm the person that will see that patient or will at least triage that phone call to decide when the patient needs to come in. So that was me this day. And I get a call from an urgent care. And the urgent care person that's working there says that this patient has double vision and looks like, and the eye is turning in. And I was like, okay, well, how old's the patient? It says the patient's 21 years old. And that kind of piqued my interest because that's not common. Oh, by the way, the patient also has severe headaches. Okay, it's getting even stranger. So when someone has double vision and the eye's turning in, and this is a new change, immediately I'm thinking sixth nerve palsy. So the sixth nerve, the abducens nerve, it innervates the lateral rectus, which allows you to turn your eye out. So if that nerve and subsequently that muscle is not working, then the eye is going to turn in because it can't go out. And so it's going to go in. And that's a pretty common problem in the right demographic. Usually when we see a sixth nerve palsy that's sudden onset, it's a microvascular sixth nerve palsy. The patient has temporarily lost blood flow to that nerve that innervates that muscle. But usually that's seen in people with a vascular history who are in their 50s and 60s. So they have diabetes, high blood pressure, whatever it is. That's common. A 21-year-old, not common. Otherwise healthy, too. 21-year-old woman. And so I'm immediately like, what's going on? Okay, so I'm thinking, what could this be? And this is all like within a few seconds, just on the phone. I'm thinking, okay, could it be a tumor compressing the nerve and causing a sixth nerve palsy? I guess, but that wouldn't be so sudden in onset typically. It's more subacute. And then why does the patient have all this like severe headache? That's a little strange. Could it be a stroke in a 21-year-old? How likely is that? I guess it's possible. It's on the differential diagnosis, right? There's no prior medical history, so it's not going to be that microvascular sixth nerve palsy. Also, could it be anything? Right? If I get a patient, if I get a call from a non-ophthalmologist and they tell me a patient has double vision, who's a young person, 21-year-old like this, if I get that call from anybody, it's usually either nothing, like the information is not exactly accurate, or it just turns out to be dry eye or nothing serious, or it's something very serious. It's like going to be one or the other. It's going to be either nothing or something very serious. Double vision, a young person, new onset with headache, either nothing or really bad. So of course I tell this, okay, send them right over to our clinic. Again, this is coming from urgent care. And so I bring the patient in like 2:00 in the afternoon. And as soon as I lay eyes on this woman, I know like this is serious. And this is a lesson, I think, for like you see so many patients that it's so important to actually just looking at the patient. When you're in a specialty like mine, that you can get a lot. I can tell if your eye is red. I can tell if you have a droopy eyelid. I can tell if you have strabismus with one glance. I can tell sometimes if you have anisocoria, if the pupils are different sizes. I can tell if you have proptosis. I can tell, if the eyes are bulging. If you have thyroid disease, I can tell. It just takes a glance. And I took one glance at this person, this woman, and I knew that something serious was going on. So she was kind of holding her head in her hands, and I looked at her eyes, and her left eye was just shoved inward to her nose. Not the eyeball itself, but the eye was just, her pupil was pointing to her nose. Clearly strabismus because the other eye was straight. And there was no movement out. Could get maybe to midline, but nothing. Good excursion up, an up gaze, good excursion down gaze, but nothing out. No what we call abduction. It's like, okay, like this is clearly a sixth nerve palsy. And everything else looked okay. Like there wasn't any ptosis. There wasn't any proptosis. So it was like, could this be like something pushing on the eye, pushing it forward, causing you to have strabismus? But there's no proptosis of that eye. It was in the same position in the orbit as the other eye. Severe headaches. And so the vision was good, but the peripheral vision was constricted in that on that eye. And then I did my kind of a first pass of an exam. I checked the eye pressure. It was normal. I checked the pupils, and they were normal. And then I dilated both of this patient's eyes. I looked back there, and there was probably the most amount of optic disc edema I have ever seen in my life. Florid, 4+, Horrible disc edema. Obviously, that's wrong. That's not supposed to happen. A sixth nerve palsy with disc edema like that, swollen optic nerves in both eyes, that's a one neuron arc to papilledema. Something is causing increased intracranial pressure in this young person's head. And so I think, well, what are the most common reasons for this? Well, you could have oral contraceptives can cause that. Idiopathic intracranial hypertension can cause that, even in young people. The classic patient is an overweight woman in her 40s, but it can happen at any age. But this patient did not have the body habitus, the demographic. It just doesn't. It didn't fit. But it's possible. But IIH, idiopathic intracranial hypertension, that's a diagnosis of exclusion. So I can't hang my hat on that at this point. Could be a tumor obstructing the flow of cerebral spinal fluid, causing increased pressure. That's possible. Like I said, oral contraceptives are known to have a risk of something like that. There's certain medications, but this patient wasn't on any of them. And it could be like a blood clot as well, cerebral sinus thrombosis, cerebral venous sinus thrombosis. Regardless of what the differential diagnosis, there's only one thing that I needed to do in that moment, was to send that patient directly to the emergency department. Fortunately, right across the street from our office. So I sent her over there. By the way, if you send a patient like that over to the emergency department, do the emergency staff a favor. Call them to tell them that you're doing that. I always do that. I learned early on in residency, always do that. I gave a courtesy call. I said, hey, I'm sending a patient right over. They can be expecting it. They can just give you an idea. I mean, it'll help just grease the wheels a bit, get the patient in. This is a very serious situation that we were dealing with. And the patient, because of the severity of the headache, the amount of edema, this patient's intracranial pressure was sky high. And so they did imaging right there. And what they found, and the imaging that you get with something like this, you need to, if you can, get an MRI. I mean, I think a CT was done, but she was able, fortunately, at that time, at that emergency department, able to get an MRI and an MRV. An MRV. You can't always get that right away. Certainly, like a CT scan was the basic thing this patient needed. We got the MRI, got the MRV that showed florid clot in the cerebral venous sinuses. Clot everywhere. Horrible. This patient ended up going to the university and being treated by the neuro-ophthalmologists up there, as well as several other doctors. Put on massive amounts of blood thinner for a long time and survived. Fortunately, that's a concern when you have something like this. This is something that can kill you. And that's what scared me when I saw this. Is like, if this is a big clot, which I thought could be a possibility, like this is life-threatening. But the wonderful physicians at the emergency department, they realized the severity of it. They got the people involved that needed to be involved. She ended up going up to the university, because this is not a typical thing. Was seen by a neuro-ophthalmologist. God bless him. I love Have I mentioned that? I feel like I've mentioned that. I love neuro-ophthalmologists. They are wonderful. And patient survived. Unfortunately, quite a bit of vision loss, which you can imagine from something like that. Massive amounts of swelling is going to cause damage like that. It starts to constrict your peripheral vision, and the last to go is your central vision. Some of that survived for this patient, but lots of vision loss. Harrowing, difficult. There are some things, Some people think ophthalmology is easy, and oftentimes it is. I have great days where I finish at 4 o'clock in the afternoon and I just breeze through. But sometimes, like that's why they pay you the big bucks in medicine, is when you get the strange things, the things you don't expect, that are life-changing for people. And so we don't often deal with life and death. That was one where it wasn't, fortunately, it didn't end that way, but it could have. So it kind of gives me like chills thinking about it still. All right, let's take a break. All right, we are back. So let's finish with a few questions from YouTube. Again, at Glock'em Go watch the Knock Knock Eye and Knock Knock Hi if you want episodes. I'll watch all the things. Watch them all. It helps. It helps us keep this podcast going. And so go watch the video, watch the episodes, or just leave a comment if you don't want to watch and you just want to leave a comment, because I love reading those. I love hearing what you guys have to say, what questions you have about eyeballs. By the way, it doesn't have to be eyeball questions that you send me. I would love, you have like a random like pulmonology question. Hey, I went to med school. I'll be honest on what I do and don't know, but why don't you quiz me? All right, test me a little. Let's see what I can do. Or give me something and see if I can relate it to the eyeball. How about that? That's a good challenge. I've been on I'm on the record as saying I can relate anything in the human body to the eyes. I stand by that. Prove me wrong, folks. At Glock'em. Go check it out. All right, so some of the YouTube comments here. I'm going to address a couple of them here. I like this one. At Daphne0123 said, I fell down a rabbit hole last night watching videos of people having foreign bodies removed from eyeballs with sharp tweezers. Do you do that? Multiple question marks with an O face. Yes, I do that. Actually, I don't use tweezers. There's different tools you can use. Sometimes, well, I won't say that. Sometimes we don't call them tweezers. We call them jewelers, because they're very fine tip point, and they're useful for pulling things off. I use jewelers like that to very delicately, not to poke the patient in the eye, but without them like being kind of as imperceptible as possible. I will use my jewelers using a microscope and pull cat hair out of people's eyes. That's a common one. And people are always surprised. It's so funny. Like, I'll do an exam on someone. I'll see a big giant hair. I don't know if it's a cat or a dog, but sometimes I can guess if the person like seems like a cat person or a dog person. Honestly, it's mostly cats, because cats tend to like crawl up on people and sleep. People sleep with their dogs too, but cats just they can get anywhere, and sometimes they get up in people's faces a lot. And so sometimes I'm examining a patient, I see a giant white cat hair, and I'll just ask them like, "How old's your cat?" And then they never told me they had a cat, but and is like, "I see you have a white cat." It's like, well, you have cat hair in your eye. It's amazing. Sometimes people, I think that's just been in there and they're so used to it, they just don't feel it. And so anyway, I use jewelers, little like very fine tip tweezers to pull cat hair out of people's eyes. For foreign bodies, though, I use what's called a foreign body spud. It looks like a golf club, but it's got not a like razor sharp, like it won't cut into the eye, but it's got a tapered edge. And so I can dig. I can use it to dig into the cornea underneath foreign bodies and kind of flick them out. I also use it to dig out, so I know it probably is making people cringe a bit to like digging in the cornea, but that's basically what I'm doing. I'm digging out the rust ring, because if you leave a metallic foreign body on the eye for too long, rust will form around it. And that's harder to get out. So that's why you want to get these metallic foreign bodies off of the cornea as quickly as possible. So, sometimes I'll use the tweezers, but not often to remove foreign bodies. But it does frighten me that you went down a rabbit hole of watching these, because I'm curious, are these trained medical professionals, Daphne, that are pulling these out? Maybe I need to do some reconnaissance here. I need to find out who's removing things from the eyeball with tweezers. Who's doing this? All right, I want to make sure they're qualified. If not, then I can make fun of them. All right. At Never Time to Try Again. I guess I was in this video, I was talking a little bit about eye drops, because this person commented, what about Lumify? I get that all the time. So many people want to know about Lumify. So if for the 1000th time, I don't mind. You ask, because, people haven't listened. Apparently, you all don't just write down everything I say to reference later. No, if you're going to use a redness relieving drop, use Lumify. The reason is because it's safer than Visine. It doesn't have tetrahydrozoline, which is the potent vasoconstrictor. Vasoconstrictor enough to give people heart attacks if they ingest it. So it's not bad as Visine. It's not nearly as bad as that. Clear Eyes, Rodo, don't use any of those. The Lumify is low-dose brimonidine, which is a glaucoma medicine. We prescribe it to people all the time. But it has an added benefit of being a mild vasoconstrictor. So it will slightly decrease that, but it doesn't have that rebound redness that you get. The problem with Lumify is that if you use it too frequently, you can develop an allergy to it, and then you have to stop it forever. All right, so yes, Lumify is okay. Use it sparingly, please. That's it. That's all I got, you guys. Everybody's talking about, okay, Visine is bad, but are there any eye drops that are good? At Rebecca Blanchard. Yes, Refresh, Sustain, Blink, Theratears, those are all fantastic brands. I would stick with the brand names, because I don't know if you've heard some of the news over the past couple of years. There have been some OTC generics that have killed people. Like Pseudomonas infections that have gotten into the eye and spread systemically. And so that's not great. For some reason, I haven't heard about that with brand names. I don't have any financial interest in any of these over-the-counter eye drops. And so, that's not the case here. Just Refresh, Sustain, Blink, Theratears. Stick with those. All right, I'll do some more questions next week. Thank you all for listening. I am Dr. Glockenflecken. Thanks to our producers, Aaron Corney, Rob Golan, and Ashanti Brook. Editor and engineer, Jason Portiza. Our music is by Omer Benzvi. Thank you all for listening. Leave comments over on YouTube, and we'll see you next time. Knock Knock Eye is a human content production.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.